Hello, everybody. Welcome to our 2024 PI Conference and our 3:30 session, Emerging Diagnostics and Therapies for CGD. My name is Megan Messick, and I'm the Director of Education here at the Immune Deficiency Foundation. And I have just a few housekeeping notes today before I introduce your real moderator, who I'm so excited to have join me today, Felicia Morton, who is the founder and Executive Director of the CGD Association of America. Oh yeah, please clap, please clap, please do. This session is going to be 45 minutes in length, and as you can tell by the glory of technology, we're going to be virtually streaming one of our presenters here. And if time permits, our presenter will be happy to take some questions, and you'll also learn a little bit more today about the CGD Association of America as well. I'd also like to take a moment to acknowledge that Emerging Diagnostics and Therapies for CGD is sponsored by Amgen, and we are just so happy to have their support in order to provide this opportunity. In addition, as you'll hear in any of our sessions today, the information presented here on stage is not intended to be medical advice. Please always consult that of your medical team and consult them for anything related to your health and well-being. And here at IDF, we offer a wide variety of educational programming provided by a wide spectrum of different life professionals, healthcare, and different facets. Please know that the views and opinions expressed by a guest don't necessarily reflect the viewpoints of IDF. But without further ado, I'm going to invite Felicia to come up here, introduce our guests, and get us started. Let's give a little round of applause.
Thank you so much. Well, this is a man who often needs no introduction in our community, the CGD community. I am so grateful to Dr. Harry Malik, who is chief of the genetic immunotherapy section at the NIH. Personally grateful to him because my son, who is sitting there in the audience, I feel that we owe his life to Dr. Malik, in fact, and many of us agree with that. From the very first moment that we met Dr. Malik, he made me feel calm. He helped me to become educated in CGD. I felt his constant support and care for Sebastian and our whole family. And every step of the way, he was with us through Sebastian after his diagnosis to throughout his transplant. And whether you have treatment at the NIH or curative therapy, or at another institution, we had ours at Duke, Dr. Malik worked hand in hand with our medical team there as well. I always felt his presence, and when it came time for me to work as an advocate, as the executive director of the CGD Association of America, I was able to call on him every step of the way there, and he works with us from our research. As you know, we have many opportunities to work together to develop research that is innovative and groundbreaking, from CGD carrier work that we've done to long-term post-transplant outcomes at the CGD Association. We really could not do it without Dr. Harry Malik. So today he's going to be talking about some of the latest news in CGD. Some of those involve what's happening with autosomal recessive, new diagnostic techniques for the P47 FOX autosomal recessive community. And then he's going to be talking about some things that we've been talking about the CGD Association of America, which are less toxic ways to have a bone marrow transplant. And as you know, at our dinner, we talked about that last night. Crystal was able to talk about her experience with her son Cyrus going through that clinical trial at the NIH under Dr. Malik's guidance. And we're also going to be talking about gene therapy, which is something we're also working on at the CGD Association of America. And so I am just so honored to be able to introduce Dr. Malik today and hopefully answer some questions if we have some time later with him. I'll be moderating that as well. So thank you, Dr. Malik.
So thank you very much for that introduction, Felicia. And, you have my admiration for all that you've done for your son and for the CGD community and for your organization skills and together this current version of the CGD Association of America. Um, my talk today is going to be a little bit different than the usual. Sometimes I'm asked to give a talk about transplant or about gene therapy or about a particular diagnostic. And I'm sure there were some other sessions here about CGD that were, somewhat didactic about transplant, maybe about gene therapy and so on. But I was asked to do something a little bit different, and we'll see how this goes today, to sort of talk about emerging diagnostics and therapies. And I use that as an excuse to sort of highlight some interesting new things and some directions toward the future that we're seeing in the CGD research and clinical area. And we'll see how this goes. And I hope to finish early enough to allow some questions about this. And so what I'd like to do is start with my first slide to, let's see, there we go. So all of you know in the audience likely already about CGD, but I'm going to use this sort of general slide where I talk about the different genetic kinds of CGD and remind you, of course, that CGD patients can have not only bacterial and fungal infections, but they can suffer from inflammatory bowel disease, inflammatory lung disease, and other inflammation problems. And I'm going to talk a little bit about, where we're headed with some interesting approaches to handling inflammation problems. But also on this slide, I wanted to point out, of course, that the X-linked form of CGD is not only the most common, but way back at the beginning, it was thought that all CGD patients were male patients, and that this was somehow an X-linked disorder only. And then it became obvious that there were girls and young women who had CGD, and so it was realized there must be also an autosomal recessive form. And then around the late 1989, early 90s, the genes for the four, what I would call original forms of CGD were discovered. That is the gene on the X chromosome called CYBB, that when mutations occur, causes X-linked CGD. And you notice that I put the percent affected as 65 to 70%, but it's probably broader than that because it depends on all those CGD occurs worldwide. There are some countries where the X-linked form is a little bit less common, and some of the other forms are more common. And I'm not going to go into specifics there, but just to say that's the reason why I put a sort of 65 to 70. It's not that we don't know an answer; it's that the answer varies by ethnicity and various countries across the world. But the original ones were the X-linked, and then these three, what we call autosomal recessive forms of CGD. And you'll notice that I'm going to return to P47 because I'm going to say something about this, that there's an oddity here. Why is this autosomal recessive form of CGD almost a third to a half as common as an X-linked form of CGD? Usually autosomal recessive forms, which require that you inherit a mutation from both parents and not just from the mother, as is the case with X-linked CGD, these diseases are usually a lot less common than the X-linked form of the disease. And you can see for this P67 deficient or P22, this is a kind of typical ratio of autosomal recessive to this. Something very odd about the P47, and I'll return to that. But in the vein of talking about brand new things, around 2018 was yet another form of CGD discovered that isn't another component of the oxidase that's missing, but rather an element that's required for the production of the X-linked form of CGD, the X-linked protein GP91. And this is called Eros. And it's actually a cytochrome chaperone. Chaperonins are sort of control molecules that help proteins fold properly in the cell. And it turns out if you're missing this folding protein, then you don't make enough of this GP91 FOX, and you have a disease a lot like the X-linked, except this is autosomal recessive, and it's encoded in a different gene entirely. So that's sort of the brand new. And I say all this because I'm sure we're going to find other forms of CGD as time goes on. But now I'm going to return to P47, and I'm going to skip something here just to move us along to P47 deficient autosomal CGD. And the background is that the P47 FOX gene, called NCF1, is located on chromosome 7 and is flanked on either side by almost similar sequencing of pseudogenes. So they're what they call very homologous, meaning they've got almost the same gene sequence. And the most common mutation that causes P47 CGD is a mutation which removes a guanine and a thymidine from a place that normally has two GTs. GT is converted to a GT at the splice receptor start site of exon 2 of NCF1. But it turns out that this delta GT is present in both of these very homologous pseudogenes in healthy humans and affected patients with P47. So making sequence diagnosis of this form of CGD very difficult. So there have been mistakes made in sequencing because this thing looks just like this thing, looks just like this thing. And if what you're looking for is a delta GT in the NCF1, you're going to have it already in these pseudogenes. But what's really interesting is that recombinational events in the region are very common. Almost 1 in 20 absolutely healthy subjects, instead of having, if I go backwards a little, if you count these, so you've got 2 pseudogenes and 1 gene, but that's on 2 chromosome 7s. So you've got 6 of these that are almost identical. In about 1 in 20 healthy people have only 7 or 5 of these. So they have, let's say they're missing one of the pseudogenes or missing one of the NCF1 genes. So there's a lot of rearrangements there. And those rearrangements include having pieces of the pseudogene drop into the NCF1 and convert it and bringing that GT. And that's the cause of the great majority of mutant alleles causing this kind of CGD. And so it explains why this is so much more common than it ought to be for an autosomal recessive disorder, and also why almost 95% of patients with P47's autosomal recessive CGD have this delta mutation in at least one of the NCF1, which is the normal gene alleles. Moreover, the pseudogenes are so homologous that several years ago, we showed that gene editing correction of that GT deletion in the pseudogenes resurrects them. So now they make a pseudogene-derived P47 FOX. And a little later in this talk, I'm going to talk about a company called Prime Medicine that's going to be launching very soon a gene therapy trial in which they come in and they repair this delta G and turns it back into a GT-GT. But instead of having only 2 genes that they can correct, they've got 6 targets. So if they fix either of the pseudogenes or the gene, you've fixed things so that the neutrophils can now make NCF1, P47. So there are actually 6 potential targets per patient if what you're doing is gene editing for P47 CGD. So in addition, there's now a new method that's been developed by Doug Coons in our neutrophil monitoring lab here connected with NIH, in which he's using a technique called PCR, where essentially they're copying a little piece of this region around the delta G, and they basically ask the question using a method called digital drop PCR. What is the ratio of GTGT to GT? And so basically, what it says is that if you've got all delta Gs, then you have P47 CGD. But if you retain any GT-GT, then you have some other kind of variation. You could be a carrier, you could be something else, but you don't have P47 CGD from this mutation. That doesn't mean that you can't still have rarely have P47 CGD, and so you've got to sequence the rest of the gene as well. But this is a way to do a quick look, and for most patients, this is diagnostic. So that's the important point is this is still in the experimental stage. It hasn't been turned into a something that's available commercially and usable for everybody. But that's why I'm talking about this as emerging diagnostics and therapeutics. Eventually, this will become one of the important diagnostics for this P47 form of CGD. So I'd like to talk about emerging therapeutics for CGD inflammation. But rather than giving you a lot of data, I'm going to give you some summaries here. And if in the question period you want to ask other questions, we can go from there. As many of you know, steroids have been the mainstay. That is, prednisone or methylprednisone have been the mainstay treatment for CGD inflammatory bowel disease. But when prolonged high-dose steroids are needed for long-term control, side effects can cause a lot of major problems. And so early on, the question was asked, could we use some of the new monoclonal antibodies, such as, one of the first ones out there for Crohn's disease was infliximab. But unfortunately, we found that if you interfere with the tumor necrosis factor pathway, it carries high risk of infections in CGD. So we sort of put that aside, but other anti-inflammatory monoclonals have been developed, and there's a whole large variety of them now that are being used in all sorts of autoimmune diseases and in Crohn's disease that target other inflammation pathways. And these seem to be relatively safe in CGD and are being increasingly used to control CGD-related inflammatory bowel disease, allowing significant reduction or even some cases elimination of the use of steroids. Examples are ustekinumab, which binds to the P40 subunit of interleukin 12-13. It's also called Stelara, vedolizumab, which targets this integrin, which is also called Entyvio, and canakinumab, which is an anti-IL-1 beta, and that also seems to help in CGD. Unfortunately, what we're finding is that not all patients benefit. Some benefit to some of these and not others. Some of them benefit and then stop responding. But fortunately, we have new anti-inflammatories monoclonal continue to be developed. And so I'm not suggesting that you start any one of these for your inflammatory bowel disease if you've got CGD, but your doctor has a lot of choices now to consider, and they can try one, and if it works, great. If it doesn't work, you can try something else, and there are more of these coming. One of the exciting things, of course, is that there's a very large class of small molecule Janus kinase inhibitors that have been approved for treatment of many kinds of autoimmune disorders. And there are preliminary ongoing experimental studies suggesting that some of these appear to be particularly effective for treatment of skin and lung inflammation of CGD. And I think some of them may even turn out to be useful for inflammatory bowel disease and CGD. So again, I'm not suggesting you excuse me, start on one of these, but that your doctor has a lot of possibilities now. So what about emerging approaches to allogeneic transplant? So first of all, who should be considered for transplant? I think anybody with CGD with really low oxidase activity, a history of life-threatening infections, or severe inflammatory bowel disease that's difficult to control. I put in yellow this progressively hypoxic inflammatory lung disease and life-threatening infections, because usually these are things that are problems that other centers will not transplant patients if they have these things. But we've had a lot of experience with this, and it seems we can, in many cases, cure a life-threatening fungal infection that's not responding to conventional management, or progressive hypoxic inflammatory lung disease. Certainly not all the time, and it's better to have a transplant before you have these things. But the emerging data is that these transplant can be used in these difficult settings. So I'd like to, there's a very interesting study published by Chesia and a whole group from Europe summarizing their chronic granulomatous disease transplant experience in 212 children and adults, published in Blood in 2020. And I think this is so many patients, so many CGD patients, that it really is the current state of the art, sort of where we are. So overall survival is about 85%, though less so in adults. Event-free survival is 75%, 69 in adults. But remember, these are all comers, including patients who may have infections and other problems going into transplant. There's about a 12% rate, meaning about a little more than 1 in 10 patients who fail to engraft. And grade 2 to 4, which is severe graft versus host disease, remains a significant problem sort of across all the general protocols for transplant for CGD, and with limited or extensive chronic graft versus host disease also remaining a problem. However, at NIH, our referral pattern is predominantly adult patients with incurable infections, hypoxic pneumonitis, and severe IBD, which requires a non-myeloablative conditioning regimen. In addition, some kinds of severe CGD can be worse than having GVHD can be worse, that is graft versus host disease, can be worse than having CGD. So we've been trying over the years to design an increasingly non-myeloablative conditioning regimen, incorporating effective graft versus host disease preventative prophylaxis. And in this single slide, what I'd like to do is to sort of give you the iterations of protocols we've conducted at the NIH. Starting in 1998, where we used this regimen, outcomes being overall survival 80%, event-free survival 70%, having sort of similar rate of graft versus host disease as the Chesia study. And then in 2007 with Elizabeth Kang, we added alemtuzumab and a busulfan, low-dose busulfan combined with low-dose TBI and a sirolimus prophylaxis. And in that group, we had an 83% overall survival with 80% event-free survival, but still had significant graft versus host disease and graft failure in about 20% of patients. So we moved on from that, now using in a protocol in 2016 to 22, adding post-transplant Cytoxan. And this seemed to make a big difference in that overall survival is still pretty good, as is event-free survival, but we ended up with 0. That's a 0, grade 3 and 4 graft versus host disease, and a graft failure rate that we reduced in half, in half from the Chesia group to 6%. And we've seen no chronic graft versus host disease in this whole group of patients. So, you know, we're in the process. We've now had all these patients out far enough that we're in the process of putting this together for publication. Although we have presented in abstract form at a number of venues, but I think, you know, the key issue here is that I think we've taken care of graft versus host disease. However, one of the things that we noticed was that we did have some deaths, but the deaths were all in patients with severe infection problems and inflammation problems who had a C-reactive protein measurement of greater than 100 in the 40 days before transplant. None among the 33 survivors had a CRP greater than 100. And so Elizabeth went back and looked at all our over 90 CGD patients and found that this was a very, very strong marker of problems. So I'm gonna go to the bottom of this and say that CRP greater than 100 pre-transplant is a predictive biomarker of high mortality risk for CGD transplants, and we felt that an alternative regimen was needed. Cytokine studies suggested that both IL-6 and high levels of gamma interferon were contributing factors. So we've come up with a new protocol that started in 2022, where for the standard risk, we've now added an anti-IL-6 antibody, this tocilizumab. But for the high-risk group, we've also added an anti-interferon antibody and an extra dose of tocilizumab early and then here at day 10. And although we're still very early, the early results to date are that we've had 2 high-risk patients who fully engrafted, and this first patient is now 2 years out from transplant and had cured a life-threatening fungal infection. The second patient is 5 months old, did have very mild GVHD, but that has resolved. And in the standard risk part of this protocol, patients are 7 to 18 months out, all are engrafted, and none have had graft versus host disease at all. So what about alternative regimens? So we think we're doing pretty well now, but we'd like to improve this further. And there's an antibody called JSP191, which binds c-KIT on stem cells. And what's needed for myeloid engraftment is some way to remove stem cells from their niches in the marrow. And of course, we and others have been using all sorts of alkylating agents as well as and/or total body radiation, but these have significant toxicities. So the question is, can we use this antibody? So this company called Jasper Therapeutics has been developing this antibody anti-c-KIT, and it binds to stem cells on the binding site for stem cell factor, thus starving the cells, and this serves to empty the bone marrow niche so that new cells can come in. What we notice, though, is that in a variety of studies, it turns out that for transplants like those for CGD, the antibody alone is probably not enough. For certain SCID protocols, the antibody may do the job, but for transplants of CGD and some other difficult to transplant immune deficiencies, it turns out, however, that the antibody can synergize with low-dose radiation. And so the two together do the job that neither the antibody nor the low-dose radiation does alone. So what we've done here is to open up a new antibody, a new protocol in which we've replaced the busulfan with this JSP191 antibody. Otherwise, the protocol is exactly the same as the patient group I went over in some detail. We use Campath, we use low-dose TBI, we use the Jasper antibody, and we use post-transplant cyclophosphamide, as we did in the other protocol, to reduce graft versus host disease. And so far, the transplants look pretty good. We're getting reasonable engraftment, and our hope is that we're going to be able to use this long term. However, we've noticed that in a few patients, we're seeing some drift downward of the engraftment. And so we're planning to add the tocilizumab that we've got in our new protocol to reduce inflammation and up the radiation just a little bit. We're hoping that will make a difference so that we get everybody engrafted. This first patient who ended up with low engraftment had a different issue, which is that we were using an algorithm to predict how long after you give the JSP to give the cells, and it turns out that we have to do a weight-based algorithm, and so that was what we used in this child, and that seemed to make a difference in the engraftment we're seeing. So out there for the future are other novel things, and I just want to say that this is not in the clinic, and we're hoping eventually this will get in the clinic. But if one could attach a toxin to the antibody, that maybe we wouldn't need to even use the radiation. In addition, there's some work done in the laboratory suggesting that one can edit stem cells to shield them from the antibody by changing the antibody target site, but retain the essential biological function of that critical protein. And that actually brings me to this long list, which I'm not going to go over in great detail, of different approaches. So there's the approach of using an anti-c-KIT antibody alone. I talked about the approach we're using in CGD right now in synergy with low-dose radiation. But then I talked to you a little bit about conjugates. And the most promising conjugate now is this molecule called tesserine, which is a small molecule that cross-links DNA. The antibody brings it to the cells take in the antibody, and then this tesserine results in killing the cells by cross-linking its DNA. So there's a lot of different things on here. I don't have time to go into them, but mostly I want to give you an idea that there's a lot going on in this area, a whole lot of different ways that people are using. And I want to end this little part of it by talking about a new paper that just came out in Nature on May 22, in which what people did was to use crystallography and AI and a variety of other things to find a site that the antibody would bind, the CD45 antibody would bind, and change it, but not change the CD45's function. So CD45 is another one of those molecules on stem cells that you could target with antibodies. And in this paper, they were able to shield the incoming cells so as to get very high rates of engraftment. And here they were also trying to eliminate a leukemia. Now, this is all with human cells put in mouse model, but it shows what the future is likely to bring us. And I think these kinds of shielding approaches and antibodies with toxin linkers on them are going to be the future, not in the very distant future, but over the next 5 or 6 years. And so I didn't want to bury you with data, but I did want to let you know that this is a really important emerging area. So what about gene therapy? Well, I'm almost running out of time, and I'm not going to give a whole talk about gene therapy. So instead, I'm going to summarize some stuff. So we, together with our colleagues in London and across the US, developed a lentivector to treat the X-linked form of gene therapy. And recently, we've worked together here in this bottom paper, develop one for the P47 form of gene therapy. There was a clinical trial that was, let me see if I have other data. So So this clinical trial was run by all these groups in Europe and across the US. And that resulted in this paper. And what's exciting about it is that although most of the adults ended up being cured of their CGD, there was a lot of problem with the children. And we think there's a lot of autoinflammation that may result in some loss of these cells. And we're working out how to try to fix that. So that resulted in some sort of delays in that study, but we're going back to get this CGD clinical trial open again for X-linked CGD using this lentivector. But right now in London, Claire Booth is about to treat her first patient with this P47 autosomal recessive vector. And we're using the same vector in a protocol that will be soon to open at the NIH. So these are sort of companion protocols, and we're working very closely together. So let me just hop forward a little bit. I don't want to. So what's in the near future for gene therapy in this last slide? So I mentioned the lentivector trial using vector for X-linked CGD should reopen at NIH. The lentivector for P47 is open at University College London, and we will be opening very soon here this same. We have a CRISPR base editing clinical trial, which just repairs the mutation in a very specific X-linked CGD mutation. And if this works out okay, we're hoping to be able to use base editing also to target other mutations in X-linked CGD patients. And what's really exciting, and I don't have time, and I'm not sure the companies would allow me to say anything, but there are companies trying to develop gene therapy that include both next generation vectors that are even more potent, I would say, than these vectors we're using here, with more natural functioning promoters. And there's also the potential for in vivo gene therapy for CGD that a number of us are very excited about and may also enter the clinic over the next couple of years. And I'm going to stop there because I didn't want to use up all the time, so that we have some time for questions. I hope my talk wasn't too scattered, but what I tried to do is to give you a feeling that there's some really neat things ongoing that are happening now. And I will stop sharing, and then we can hear about any questions anybody has.
Thank you so much, Dr. Malik. And there he is, the man himself. Does anyone have any questions for Dr. Malik? Oh, I'll come right down. Okay.
Hi, great talk, Dr. Malik. I had a question about when you were saying that you're adding an anti-inflammatory regimen in the transplant. Is it, at what point are you adding this? On the day of infusion, a week prior, a month prior, how far in advance?
So for the it's going to be at 10 days before the transplant. I probably very quickly went through the high-risk patients where we're adding the anti-inflammatory anti-IL-6 twice, one really early at minus day 21 and then one at day 10, minus 10. But then the anti-gamma interferon one for the high-risk patients is being added just on the day before the patient gets the transplant cells. And that part is already in the clinic for the high-risk patients and the regular risk patients for the busulfan protocol. But we thought we'd add the tocilizumab to make it more like what we're doing in our busulfan protocol now with the briquilimab, the JSP191 protocol. Does that make sense?
It does. One more question. Can you talk a little bit more about the pediatric patients and what you're seeing, in terms of gene making?
This is an issue that's been very vexing in the whole gene therapy for CGD community, across our whole community. We were so successful in a number of adults, and I had to rush through my talk, but we've got 3 adult patients treated with that lentivector who really have cured their CGD, but across the protocol in the UK and here, none of the children retain those gene therapy cells, and we think that they're rejecting them in some way, and we haven't quite figured out what part of their immune system we need to suppress to make this happen, or if this is just an inflammation issue and that children have CGD children have more inflammation problems. I wish I could give you a straight answer, but we don't have a firm answer. But we are going to begin to open our protocols. We're going to start with adults and work our way slowly downward and try some things and see if we can solve this problem in the children.
Do we have any more questions? Okay, well, I have some questions. I think based on his talk, we're all curious about when some of these clinical trials will be available to our patients, and I know we can go to clinicaltrials.gov, and if you have any further information on how our patients can sign up or learn more about them, that would be something that would be helpful for our community as well.
So of course, transplants for CGD are being successfully applied all across the country and the world. And while people are using slightly different methods, we all talk to each other, and people are bringing many of the approaches that we've all talked about into the clinic. So I think, with respect to curative treatments for patients with CGD, the transplant physicians, as I say, across the U.S. and the world are really moving ahead with that, and patients who need those transplants, don't lack places where they can get them done. And while we have a transplant protocol open and we're trying new things here at the NIH, I don't want to suggest to people that they wait for the NIH trial if their patients, I mean, your own son, for a variety of reasons, we sent to Duke, and they did a fabulous job there, and they still do a fabulous job. So I don't want to paint a picture where it seems like only NIH is the place to get your treatments for CGD. Our goal is to invent new things and try to improve on the things we're doing, but that then means the things we're doing are experimental. They're not the established, they're experimental. Hopefully we lead the future in that, and that they get applied elsewhere once they're established. As it relates to gene therapy, however, there's unfortunately very little going on, and we're trying to reopen these things. We ourselves are trying to reopen this X-linked CGD clinical trial for gene therapy. But I will tell you that that there are other companies working on gene therapy approaches for CGD, and some of them are going to come online very soon. Prime Medicine has this very inventive protocol for P47 CGD, and we're all looking forward to that opening in the near future. We're of course also exploring lentivector, but I think that fortunately a lot of CGD patients who need therapies can find them. For those who can wait, the near future is going to be pretty exciting, I think. Again, I'm not sure I answered your question fully, but for the gene therapy, it's going to get busier, and there's going to be more opportunities for people. Right now, things are a little tighter, but I think over the next year or two, things are going to change.
Thank you so much. And this is why we love talking to Dr. Malik, and at the CGD Association of America, we like to talk about what's happening now, what's available now, what are your options now, and what to look forward to in the future. You can learn more about CGD Association of America by going to www.cgdaa.org. You can see interviews and various projects we've worked on with Dr. Malik as well. And if you have any further questions, feel free to get in touch with me. And I'm always happy to connect you with Dr. Malik as well. Thank you so much, Dr. Malik. It's always insightful, always interesting, and we always learn so much from you.
Thank you so much. I'm glad to. Sorry I couldn't be there in person, but this was a lot of fun. And I see we finished right on time. Thank you.
Thank you so much again. And one just quick note from IDF, and then I think we're going to actually get a group picture on stage of some folks while we're all here together. But thank you again. We would love to get your feedback in our conference app. You'll get a small session survey that you can access so long as you have this session out in your agenda. And please visit primaryimmune.org where you can find additional information regarding Ask IDF and our Get Connected groups. But thank you again, and we'll briefly move to our group photo.